Now that we're out of the Garden of Bleeding, we can take a look at some of the problems encountered further down the reproductive tract, namely the cervix. We'll start with benign pathologies, like cervical polyps. Then we'll venture into the complex ecosystem of cervical epithelium metaplasia, dysplasia, and, of course, malignancy. First, though, a little background about the design of the botanical garden. See that round area on the left? That's the uterus. And to exit the uterus, we head through the cervix, of course. In this sketch, the cervix is embodied by the staircase in the center there. The stairs proceed through what's called the endocervical canal. The connection between the uterus and the cervical canal is the internal os, while the distal opening at the end of the staircase is the external os. At the external os, the endocervix that forms the canal transitions to the exocervix, which opens up and is exposed to the acidic environment of the vagina. The exocervix, in other words, is that pink donut you can see on colposcopy when viewing the cervix through the vaginal canal. In this scene, however, because we're looking at the vertical cross-section of the cervix, the exocervix takes the form of those two round projections on each side of the stairs. All right, let's look at histology. The epithelium that lines the endocervix looks more like the uterus. That means it's comprised of mucus-secreting columnar cells. Just think of these chubby columnar caterpillars on each side of the staircase. The exocervix, on the other hand, looks more like the vagina, so it's lined by stratified squamous epithelium, as depicted by these flat squamous butterflies that line the rest of the botanical garden wall. While we're on the topic of endo versus exocervix, I want to mention a non-cancerous lesion that occurs relatively frequently, the endocervical polyp. Like its name implies, cervical polyps arise from the endocervix. These benign lesions can be as large as a few centimeters and even protrude out of the external os. On histology, they're composed of the same mucousy columnar epithelium as the endocervix. Endocervical polyps most commonly affect middle-aged women around the time of menopause. She's brought all of her kids along as well to remind you that having a history of multiple pregnancies increases the risk for polyps. Most of the time, they're asymptomatic. However, when they do cause trouble, abnormal vaginal bleeding and discharge are the most common symptoms. Removal of the polyp is definitive and curative. So don't worry there, little Braden. Just cut it off, and the apple's good as new. There you go, kid. Enjoy. All right, let's continue our tour of the cervical epithelium. Where the columnar epithelium joins the squamous epithelium is dubbed the squamo-columnar junction. And before puberty, this intersection occurs right at that external os at the end of the stairs. With the onset of puberty, however, the squamo-columnar junction everts, bringing the columnar epithelium out onto the exocervix. It turns out that the columnar cells don't really like it out there. See all those milky white flowers that line the vaginal canal? That's our sketchy symbol for lactobacillus, a bacterium that lives in the vagina and produces lactic acid, thus exposing the vagina and exocervix to a harsh acidic environment, usually around a pH of 3.8 to 4.5. We've even made the stamen look like little gram-positive bacilli shapes. See? To deal with the decrease in pH, the columnar cells undergo metaplasia. That's right. It's like a metaplastic metamorphosis, turning those columnar caterpillars into squamous butterflies. Pretty, right? This area of the exocervix, where columnar to squamous metaplasia is occurring, is called the transformation zone. Remember, this is a completely normal process. Metaplasia is simply a way for the columnar epithelium to toughen up and transition to a stratified squamous layer that's more acid resistant. Now, metaplasia does not mean dysplasia, the precursor to cervical cancer. However, the transformation zone, right where all this metaplasia is occurring, is also where cervical dysplasia and cancer arise. Why here at the transformation zone? Well, like many other types of cancer, it results from a physiologic process that goes haywire. In the cervix, dysplasia has a fancy name: cervical intraepithelial neoplasia, often referred to as CIN. CIN is a precursor to squamous cell cervical cancer. The vast majority of CIN cases are associated with HPV, so let's spend some time talking about the virus. Uh-oh, looks like someone left the door to the bug house open again. Recall from Sketchy Micro that human papillomavirus is represented by papilloma pill bugs. Now, this may look like the cutest infestation in the world, but HPV can do some serious damage. HPV comes in many types, over 150 in fact. Two of them, types 6 and 11, are associated with genital warts and therefore are classified as low risk. Most other types, including 16, 18, 31, 33, etc., are associated with CIN and cervical cancer and therefore are classified as high risk. The most common are 16 and 18, and just like in Sketchy Micro, 16 is represented by car keys, since 16 is the legal age to obtain a driver's license in the US, though you need to be a bit older in many other countries around the world. And 18? Well, 18 years old is a pretty universal standard for the legal voting age, and that's why this concerned Butterfly Garden employee is wearing the I voted sticker. So there you have it. Type 16 and 18 for high-risk HPV strains. High risk means that these strains of HPV are able to integrate their DNA into the host genome, where they inhibit the cell cycle regulatory proteins P53 and RB. Again, we've brought back the same symbols from Sketchy Micro. Take a look at the overexcited garden visitor who has inadvertently started this whole papilloma pill bug outbreak. P53 is like the checkpoint of the cell cycle, preventing the G1 to S transition. So at Sketchy, we represent P53 with, well, a checkpoint, like the one being blatantly disregarded in the back there. And RB? A cold glass of root beer, of course. Obviously not permitted in the butterfly house. RB is also responsible for restricting cell cycle transition from G1 to S. Notice that because these are both tumor suppressor genes, we've also included a recurring cancer-fighting ribbon. After integrating into the genome, high-risk HPV strains upregulate the production of two inhibitory proteins, E6, which blocks P53, hence the flipped-over number 6 there, and then there's E7, which inhibits RB, and is emphasized by that 7-shaped straw in the root beer glass. By blocking these tumor suppressor genes, HPV kicks cell replication into hyperdrive, causing uncontrolled growth and, eventually, cancer. All right, as you can imagine, factors that increase a patient's risk for developing cervical dysplasia and cancer include, well, anything that increases a patient's exposure to high-risk types of HPV. Since HPV is a sexually transmitted disease, think of things like a history of multiple sexual partners, early onset of sexual intercourse, and unprotected intercourse. Whoa, buddy. I know with all the butterflies and pollination and stamens, it can get pretty hormonal in here, but you gotta slow down. Immunodeficiency is another important risk factor. In healthy, immunocompetent people, the immune system is often able to suppress the HPV infection. However, a compromised immune system isn't able to do so, allowing the virus to infiltrate the patient's DNA and wreak some oncogenic havoc. Interestingly, smoking is also a risk factor for cervical dysplasia. It's thought that smoking can cause direct damage to the cervix. It may also inhibit cellular DNA repair mechanisms, thus allowing HPV to integrate its DNA more effectively. Unlike many other types of gynecological cancer, family history of CIN or cancer is not a risk factor. CIN appears to be an acquired disorder driven by infection with HPV. All right, I want you to pay close attention to where those HPV pill bugs are headed. That's right, straight for that transformation zone on the exocervix. It turns out that HPV has a special affinity for those immature squamous cells that have just undergone metaplasia from columnar to squamous. So, right as those squamous butterflies leave their cocoons, wham! Those HPV pill bugs attack. Again, this is all taking place after metaplasia has occurred. So we're talking about squamous cell carcinoma here. Adenocarcinoma is possible, but more rare. I'm getting a little ahead of myself, because before we get into fully fledged cancer, there are a few cellular changes to know. On histology, HPV causes koilocytosis within squamous epithelial cells. Koilocytes are dense, with irregularly staining cytoplasm, and most characteristically, they exhibit paranuclear vacuolization. In this scene, koilocytes will be embodied by these koilocytic koi fish. You see those dilated eyes? The koilo prefix means hollow or empty. So look for a perinuclear clearing that makes a halo around the nucleus. Kinda like the clear sclera that surrounds that dilated pupil. The nucleus will also look enlarged, with an undulating or raisin-like border due to condensed chromatin. I want to emphasize one point here. As the koi gobble up those HPV pill bugs, keep in mind that coilocytosis of a cervical epithelial cell is merely a sign that the cell is infected with HPV, but this tells you nothing about cancer. Patients with HPV-infected cells who are young and have a strong immune system will usually clear the virus. No harm done. Dysplasia, on the other hand, is the precursor to cervical cancer. When HPV integrates into the host DNA and causes cell replication to go crazy, the resulting dysplastic cells will show decreased cytoplasm and a big, dark-staining, weird-looking nucleus. I mean, compare these mangled butterflies to the normal ones below. They just don't look like squamous cells anymore. When a histological tissue sample of the cervix is taken, these dysplastic cells are termed cervical intraepithelial neoplasia, or CIN. HPV likes to infect the epithelial cells near the basement membrane, also called the basal cells of the epithelium. So, dysplasia starts from the bottom up. See how the mangled dysplastic butterflies accumulate on the bottom of the tank? CIN is categorized into 3 classes, creatively named CIN 1, 2, and 3. Highlighted here in the koi tank marked C inside. CIN 1 is characterized by mild dysplasia involving the lower or basal 1/3 of the epithelium, while the rest of the epithelium exhibits normal stratified squamous cell characteristics, though you may spot some HPV-infected coilocytes in those upper layers as well. Hence the koi fish swimming around above the steady accumulation of dysplastic cells. CIN 2 is characterized by moderate dysplasia, involving the lower basal 2/3 of the epithelium, usually with some coilocytes above. CIN 3 is marked by severe dysplasia involving up to the full thickness of the epithelium. When that happens, it can be called carcinoma in situ. The cells are disorganized and just kinda dark purple and gross looking. Once the dysplasia breaks through the basement membrane, right through the glass of the aquarium, if you will, then it becomes frank cervical carcinoma. Now, progression from CIN 1 to CIN 3 and cancer is a slow process. It typically takes about 10 years to progress from CIN 1 to CIN 3, and another 10 years for CIN 3 to progress to overt cancer. Pretty straightforward, right? Well, it turns out that dysplasia doesn't have to progress this way. I'm telling you, your immune system is pretty effective in eradicating that nasty HPV bug. CIN 1 is also called LSIL, or a low-grade squamous intraepithelial lesion, because CIN 1 usually resolves spontaneously in young, healthy women. That's right, just like this immune filter here, filtering out those dead dysplastic butterflies. CIN 1 is largely controlled by the immune system and will most likely not progress to cancer. LSIL means low grade. As such, we've made the CIN 1 tank lower than the rest of the aquarium. For all intents and purposes, HSIL, or high-grade squamous intraepithelial lesions, represents dysplasia that incorporates over 1/3 of the epithelium. In other words, CIN 2 and CIN 3. These are deemed high-grade because, more often than not, they progress to cancer, albeit very slowly. Notice that the immune filter responsible for maintaining the CIN 2 and 3 section is all clogged with dysplastic butterfly corpses. There's no stopping it now. Cancer, here we come. In reality, even some of these high-grade lesions regress. However, around 10% of these patients will develop invasive cervical cancer in 10 years if left untreated. Remember those risk factors we mentioned earlier as well. People with immunodeficiency, such as AIDS patients or smokers, are more likely to have CIN progress to cervical cancer, and to do so more quickly. You know what? This whole time we've been talking about the histological progression of cervical dysplasia, but how do you even obtain a sample in the first place? It's time to bring in the old Papa Nicolau test, which I can only guess is either a portmanteau of Pinocchio koala or possibly an anagram of a anal coop up. Whoop, nope, scratch that. It's some old Greek dude's name. Anyways, the PAP test is a screening test used to detect cervical dysplasia and cancer, with the goal of detecting and treating CIN before it progresses to frank cervical cancer. A pap smear is performed by taking a swab of the cervix and looking at the cells gathered under the microscope. The tool used is usually a little spatula or brush, kind of like this one. And all you have to do is sweep around the cervix, making very sure you're sampling the transformation zone. Remember, that's where all the craziness happens. Optimally, you should see both metaplastic squamous cells and mucus-secreting columnar cells picked up from each side of the squamo-columnar junction. An abnormal pap smear result may have some chylocytes or even evidence of those out-of-control dysplastic cells. Holy crap, you guys! When was the last time the tank was cleaned? This can be combined with HPV typing to figure out if you're dealing with high-risk strains. Remember, the presence of high-risk HPV types is the biggest risk factor for CIN and cervical cancer. Keep in mind here that we're only obtaining cytology. Under the microscope, all you'll see is a glob of cervix cells. A pap smear will tell you nothing about the histological architecture of the epithelium. In other words, if you really want to define CIN 1, 2, or 3, you need to get a tissue biopsy. Now, really young, healthy women with just a few chylocytes kind of fall into their own category and may not always need further testing. For most patients, however, if abnormal cells are detected on pap smear, a colposcopy is performed, in which the cervix is directly visualized with a scope after applying acetic acid to the cervix. Acetic acid turns the areas of the cervix white that are more likely to have cellular crowding and dysplasia. Not a good sign. Time for a biopsy. Only then can we properly define CIN versus invasive cervical cancer that's penetrated the basement membrane. So what do you do once you find CIN? Depending on the severity and age of the patient, therapy ranges from close surveillance, i.e. frequent pap smears, to ablation of lesions, via cryotherapy or lasers, or even complete excision of abnormal parts of the cervix, via a LEAP procedure. All right, let's finish up our discussion with the worst case scenario. Invasive cervical cancer. Cervical cancer is most often squamous cell carcinoma, approximately 80%, but can also be adenocarcinoma, around 20%. The average age at presentation for cervical cancer is 45 years of age. Cervical cancer results from progression of CIN, but remember, it takes about 10 years. Yeah, 10 years for CIN3 to progress to frank carcinoma. So early detection via pap smears and prevention from the HPV vaccine have greatly decreased the incidence of and mortality from cervical cancer. In the US, it's currently the third most common gyne cancer and the third most common gyne cancer causing mortality. Cervical cancer is far more common in developing countries without access to these preventative measures. In the developing world, it's the second most common overall type of cancer and the third most common overall cause of cancer mortality. On histology, squamous cell carcinoma appears as typical invasive squamous cells, forming the keratin pearls and intercellular bridges classic to most forms of SCC. Adenocarcinomas typically appear as crowded glands. When cervical cancer spreads, it does so locally in a down and out fashion, meaning that it extends inferiorly into the vagina and laterally into the pelvic cavity. Just think of the aquarium glass breaking, sending those dysplastic cells down and out across the floor. Lateral extension frequently involves the bladder, leading to obstruction of the ureters and postrenal kidney obstruction. The renal failure that ensues can be fatal. Cervical cancer is often asymptomatic in early stages, but may present with postcoital bleeding, almost like post-pollination bleeding, if you catch my drift. Cervical cancer is treated with surgery and radiation. Fortunately, given cervical cancer's relatively indolent nature and early diagnosis via routine pap smear, the prognosis for patients is very favorable, with a 5-year survival rate of more than 70%. Luckily, besides counseling your patient on the importance of safe sex and smoking cessation, as we briefly mentioned earlier, there's also an HPV vaccine available. Hence the vaccine's syringe-themed guardrail, protecting the kids from the mayhem below. The HPV vaccine protects against 9 common types of HPV: 6, 11, 16, 18, 31, 33, 45, 52, and 58. All boys and girls between 9 to 26 years old should be offered the vaccine, Women who have received the vaccine should still receive pap smears because there are other, less common strains of HPV that are not covered. Well, that's it for cervical disorders. Be sure to check out our other videos to round out your education of gyn malignancies, including our videos on uterine and ovarian cancers. I have to help clean up here, but I'll catch up with you at our next sketch, which takes place at the entrance of the botanical garden. And yes, by entrance, I mean vagina.